Hello everyone, you're much welcome at Medical Sciences, where we want to discuss about antimalarials, drugs used to treat different types of plasmodium that are causing malaria in human beings, and different types of malaria species we have P. falciparum being the most common cause of malaria in human beings. Then we have P. malariae, P. vivax, and P. ovale. Then the recent is Noresi, P. noresi. So these are the 5 species of plasmodium that are known to cause malaria in human beings. And the infective stage, which are the sporozoites of falciparum, malariae, vivax, ovale, and noresi, are being transmitted by female Anopheles mosquito. So if we have a female Anopheles mosquito biting man, it injects what we call the sporozoites, which are the infective stage. So these sporozoites injected in the blood are transported to the liver. And when the sporozoites reach in the liver of a human being, they transform into what we call the schizons. They form what we call the schizons. And these schizons continue maturing, many of them, and when they mature in the liver cell ruptures to release what we call, because one schizon can contain more than 10 merozoites. So they release what we call the merozoites. These are the merozoites. These ones we can call them merozoites. And the stage in the liver where sporozoites transform into schizons containing different merozoites, is known as pre-erythrocytic schizogon. Pre-erythrocytic schizogon. Then some malaria parasite species like P. ovale and P. vivax, for them they are malaria parasites undergo dormant stage. Instead of developing into a mature schizons to release merozoites, for it undergoes a dormant stage known as hapnozoid. It undergoes a dormant stage known as hapnozoid stage, and this is what we are calling the dormant stage. And this dormant stage in the vivax and ovale is known as exoerythrocytic schizogon. Exoerythrocytic schizogon. These are the asexual forms. This was pre-erythrocytic schizogon. That is for P. vivax and ovale. Whereas for the falciparum, the malariae, and other species, these merozoites continue to attack the red cells. And when they attack red cells, these merozoites transform into what we call the ring forms, known as the trophozoites. They transform into what we call the ring forms. These ring forms, they are known as trophozoites. And these ring forms mature into schizons, which schizons mature to release still the merozoites. And even they can transform into gametocytes. But these schizons contain also multiple merozoites which can be released after the RBC rupturing so that they can attack new red cells. And this stage in RBC is known as This stage occurring in the red cell is known as erythrocytic stage, from the word erythrocyte. Erythrocytic. Pre-erythrocytic schizogony, it means it is the cycle, a sexual cycle before merozoites reaching the RBCs. Then pre-erythrocytic, that erythrocytic is in the red cells. So after these schizoids releasing merozoites, when the female releasing gametocytes, that is male and female, when the female Anopheles mosquito is coming to take a blood meal, it can take these gametocytes, which reach into its gut. They undergo sexual reproduction, which will form the ookinete, which penetrate into the gut and transform into sporozoites, which will be taken by the Anopheles mosquito when it is taking a blood meal from another human being. And in the mosquito stage, that is what we call sexual or sporogony stage. But in a human being, we have a sexual, which is schizogony stage, which is divided into three. That is pre-erythrocytic, exoerythrocytic, and erythrocytic schizogony stage. So we are going to see that these stages are targeted by different antimalarial agents. For example, with pre-erythrocytic stage is well targeted by a drug known as Primaquine. Primaquine is a drug of choice for targeting liver stages. But apart from that, we can also use Proguanil. Can be used. Then with exoerythrocytic, only Primaquine is being utilized to treat dormant stages which can cause relapse. This is a condition whereby you treat the patient after 2 weeks till they come up again with malaria. Treat them after 2 weeks, they still come back with malaria. That is, the drug of choice you can use is Primaquine, meaning that those guys are going dormant stages known as hypnozoid stage. So you can use Primaquine. It is the only drug we can use in exoerythrocytic schizogony. Then drugs being utilized to treat the trophozoites and the schizoids within the liver, which we call erythrocytic. We have drugs like Artemisinins. We have Artemisinins. We shall have drugs like lumefantrine or harofantrine. And have drugs like antifolates, as we shall look at them. What are they? We shall get drugs like Atovacon, drugs like Mefloquine, Amodiaquine. Then we shall have Chloroquine and many others. Even Primaquine can also target this. So Primaquine targets all stages. We have also Primaquine. Then we have another one like Quinine. Then Doxil, which is given in combination with quinine. So these are the drugs which can target the blood forms of malaria parasites, as you're going to see them one by one in details. Then there are also those ones which can target the gametocytes, that is the male and the female. And those which can target the gametocytes, still Primaquine is the drug of choice for that. Primaquine, then even Chloroquine, when given in combination, can also target the gametocyte stages. So what have we seen? That Primaquine can be used to treat all stages of malaria parasite in a human being. That is in the liver, in the blood, the dormant stages, and even the gametocytes. So we can use it as a radical cure. And that's why we are starting with it as number 1 drug, that is Primaquine, which is used to treat all stages of parasite, and we call it radical cure. So when all other drugs have failed and you have a relapse, you can easily use Primaquine. And also when treating non-PF malaria parasites like Vivax and Ovari, you need Primaquine, because Primaquine can target all stages. And this Primaquine, its mode of action, it acts as the oxidant, as an oxidant, which oxidizes the iron within the malaria parasite, leading into a toxic metabolite which kills the malaria parasite. So it does it by oxidation. That is Primaquine. And this Primaquine, as it is a good drug which targets all stages, it is contraindicated, or its adverse reaction, it can cause hemolytic anemia. In people with glucose 6-phosphate dehydrogenase deficiency. Then it can also cause methemoglobinemia due to its ability to convert iron 2 into iron 3, that is methemoglobinemia, which can lead to jaundice, mild jaundice. Then this Primaquine is contraindicated in pregnancy. So never give Primaquine in pregnancy. It is contraindicated in pregnancy. And G6PD deficiency, and being used as a radical cure to target all forms of malaria parasites in a human being, and also non-PF malaria parasites like Vivax, Ovari, and Malaria, which is a good drug for treating these parasites. So this is the Primaquine as number 1. Number 2 we can look at is Artemisinins. But before we look at Artemisinins, let us first look at Quinine. Quinine is derived from a natural herb known as cinchona, and it is always given in combination with the doxycycline or clindamycin to shorten its duration to shorten on the time you give the quinine, and also to relieve on the side effects you give it in combination with the doxy. And this quinine, its mechanism of action. But before we look at its mechanism of action, when given IV, it should be given in combination with D5, that is dextrose 5%, to prevent hypoglycemia, because this quinine is known to induce production of insulin from the beta cells of the pancreas. So when high amounts of insulin are produced in response to quinine, they cause all the sugars or glucose within the blood to be taken into cells, hence leading to hypoglycemia. So we don't give it with normal saline, but we give it with D5 or sugared drink if you don't have D5, to prevent hypoglycemia. And its mechanism of action is that if I have an RBC, and this RBC has inside the malaria parasite, this RBC contains hemoglobin, which is taken by the parasite and it is converted into heme. This heme is toxic to the parasite. So what the parasite do, it converts this toxic heme into non-toxic hemozoid, which the parasite can tolerate. And this process is known as polymerization, catalyzed by enzyme polymerase. So that is how the parasite is able to survive. But when you give a drug like quinine or chloroquine, it comes and inhibits polymerase enzyme that converts toxic heme, into non-toxic hemozoid. And what happens? the heme which is toxic to the parasite accumulates, leading to the death of the parasite. That is its mechanism of action, preventing conversion of toxic heme to hemozoid, which is non-toxic. So the toxic heme accumulates in the food virtue of the parasite, leading to its death. So, and its mode of action is the same as with chloroquine. And this quinine is being indicated in complicated malaria. You can give it in complicated malaria as a second alternative to artesunate, and also in pregnancy. It is a good drug given in pregnancy, but never forget we give it with the D5 to prevent hypoglycemia. And one of our other forms, apart from hypoglycemia, what are other adverse reactions with quinine? Quinine causes what we call chinconism, which is characterized by allergic reactions on the skin, like rash. You can get otitis, that is, it affects the hearing part. It can cause bull's eye, which can lead to blindness when taken in higher doses. These are other sides, and also GIT distress. That is why its use is so much limited due to its chinconism reactions when taken. That is quinine. Then another drug we can talk about, number 3, is chloroquine, which is no longer being used. Chloroquine is no longer being so much used due to its PF resistance. Plasmodium falciparum has developed resistance to chloroquine, and its mechanism of action is the same. The mode of action of chloroquine is the same as quinine by inhibiting formation of non-toxic hemozoid, leading to accumulation of heme, which is toxic to the malaria parasite. And this quinine is being given in patients to treat non-PF malaria. That is malaria ovarian, vivax, and malaria. And in some areas which are sensitive to quinine, which have PF which is sensitive to quinine, we can give, sensitive to chloroquine, you can give it. You can ask yourself, how has the malaria parasite developed resistance to this chloroquine? That if I have a malaria parasite like this, they have developed what we call the efflux pump. And this efflux pump, that whenever the quinine enters inside, it is pumped out. Whenever it enters, it is pumped out. So it is due to development of the efflux pump that pumps out the chloroquine. Hence, we cannot attain the enough dose to kill this malaria parasite. And this chloroquine is known to cause hepatotoxicity, can cause hepatotoxicity and allergic reactions. This is chloroquine, used to treat non-PF malaria parasites plus areas which are sensitive to PF with chloroquine, and also used as a prophylaxis, chemoprophylaxis, to prevent malaria. That is chloroquine. Another category of drug we are going to look at in this session is artemisinins. And these artemisinins, they include drugs like artemether, can begin with artesunate, then artemether, we have artemether, and even the active form which is known as dihydroartemisinin. Artemisinin. This is the active form. These are prodrugs that when taken in the liver, they are converted into active form dihydroxyartemisinin, which is the active form. And these artemisinins are derived from a plant known as Artemisinin chinua, which is a Chinese herb, which was previously being used for treating fever. So it is from the herb. And these drugs In the drug or malaria management policy, we are going to see how artesunate is being used to treat severe malaria or cerebral malaria. That is artesunate IV in combination with artemether, or we can combine artemether with lumefantrine in the treatment of uncomplicated malaria, which we are going to see under malaria policy guideline. But these drugs we are seeing, what is their mechanism of action? They act by developing free radicals, by development of toxic free radicals. And when they develop these toxic free radicals in the food virtue of the parasite, they lead to the death of the parasite. That is how they act. That is artesunate, artemether, and artemisinin. Given in combination, either artesunate can be given IV, followed by artemether lumefantrine, or we can give artesunate IV versus amodiaquine, or artesunate mefloquine, or artesunate diethiotoxin, as we are going to see it under policy in management of malaria. So for now, this is what we can talk about artemisinins being used, for example, artesunate for severe malaria, artemether for uncomplicated malaria. So the next kind of drug we are going to discuss in this session is the antifolates. So we are going to have the antifolates. Whereby the antifolates, which is category number 5, for them they are targeting folic acid synthesis, and they include Proguanil, which is the prodrug. Its active form is cycloguanil, is the active form. We have pyrimethamine. Pyrimethamine is also an antifolate. We have sulfadoxine. Then we have dapsone. These are the major antifolates being utilized in treatment of malaria. And these drugs, for them, they are being used to treat PF, Plasmodium falciparum, which is resistant to chloroquine. If we are in areas which have Plasmodium falciparum resistant to chloroquine, we are giving these antifolates. And what is their mechanism of action or their mode of action? How do they kill the parasite? In the parasite, we have what we call PABA, para-aminobenzoic acid. And this para-aminobenzoic acid is converted to dihydrofolate. Then the hydrofolate is reduced to tetrahydrofolate, which is a precursor for folic acid synthesis. And this folic acid is utilized in formation of DNA and RNA. And which enzyme catalyzes this reaction? This one is dihydroopterate synthase or synthetase. Then this is dihydrofolate reductase enzyme. And we're going to tell you that Proguanil and pyrimethamine, they target the first enzyme in folic acid synthesis, whereby they inhibit dihydroopterate, that is Proguanil and pyrimethamine. Whereas sulfadoxine and dapsone, they target all the enzymes which participate in folic acid. So for them, they inhibit dihydroopterate synthase and dihydrofolate reductase. That is dapsone and sulfadoxine. Whereas Proguanil and pyrimethamine only the synthase. That is their mechanism of action. And without the parasite forming folic acid, they cannot form the DNA which they need to multiply to form more parasites, hence killing the parasite. And these drugs, as we have said, they're being indicated in chloroquine-resistant PF malaria. We can utilize them. Although we shall see that they are given in combination. For example, there is Malaria being used in treatment of also complicated malaria, where you have Atovaquone being given in combination with Dapsone in treatment of complicated malaria and chloroquine-resistant malaria, PF. We are also giving in combination sulfadoxine, pyrimethamine, this is locally known as Fancida, and being utilized as the prophylaxis. It is used as a prophylaxis in preventing malaria, especially preventing malaria in pregnancy, and this one is given in the second and third as a prophylaxis to prevent malaria in pregnancy. But if the pregnant mother is HIV positive, here you don't give sulfadoxine pyrimethamine, which is Fancida. Here you consider to give Septrin, which Septrin is having cotrimoxazole. So in HIV pregnant mothers, we give Septrin, not Fancida, to prevent malaria. And what else do we use Fancida as a prophylaxis? If someone is moving from tropics or areas known as to be endemic with malaria, you first take Fancida as a prophylaxis. That is what we can discuss with you. And we saw that proguanil can also be used to target the schizont forms in the liver hepatocytes, apart from Primaquine being used. So these are the drugs we can discuss with you. So we want to see our malaria drug policy. What is the policy or the guideline, malaria management guideline? Which drug should we use in different types of malaria? We are seeing in complicated malaria, someone who has complicated malaria, the first line is Artemisinin. The first line is Artemisinin IV or Artemisinin rectal in children. And this Artemisinin is given 3 doses at 0 hour, at 12, and at 24 hours. And if it is a child below 20 kgs, you give 3 milligrams per kg. And for adults beyond 20 kgs, you give 2.4 milligrams per kg for 3 doses at 0, 12, and 24 hours. Then you resume with the artemether lumefantrine, that is Coartem. This is locally known as Coartem, for 3 days. That is oral tabs. Or the alternative which we are currently using, in case we don't want to use Coartem, we can use Artemisinin IV, then you continue with the Deoxycycline. Deoxycycline is dihydroartemisinin peperaquine. This is a combination. So if this Coartem is not working, we can use Deoxycycline or Diatep after finishing 3 doses of Artemisinin. Then the second alternative for complicated malaria, the second alternative you can give is IV quinine given with D5. And this IV quinine is very safe in pregnancy. You can use it in treating malaria in pregnancy, but is always combined with doxycycline or clindamycin. It is always given in combination with the doxa or clindamycin or tetracyclines so that we can reduce on the dose and we prevent chinchonism symptoms of the quinine. In the past years, we have been saying artesunate is contraindicated in the first trimester of pregnancy, but for the recent research has shown that in African women, artesunate has no problem or has no teratogenic effect on the fetus in the first trimester. So artesunate and coartem can be given now in pregnancy due to research found out on the African women that they can tolerate this artesunate dose. So this is how we can manage complicated malaria or severe malaria. And how can we manage uncomplicated or mild uncomplicated malaria? For uncomplicated malaria, the first line being recommended is artemether-lumefantrine. We are giving artemether-lumefantrine, that is coartem, as the first line. If you do a BS, that is blood film, and you find a +1, that is what we are calling mild malaria. Here you can utilize coartem as the first line. Or you can use, if coartem does not work in uncomplicated malaria, you can give artesunate amodiaquine. You can give artesunate amodiaquine, or you can give artesunate mefloquine. Can also be utilized, or you can give artesunate. We have artesunate amodiaquine, we have artesunate mefloquine. These ones can also be utilized in treatment of uncomplicated malaria. Then also chloroquine in areas which are PF sensitive can be used in treatment of uncomplicated. So uncomplicated malaria, we are using artemether-lumefantrine, that is coartem. But also the alternative is artesunate amodiaquine or artesunate mefloquine. We can also use deoxycycline, but though deoxycycline is majorly used in combination during complicated malaria. So this is what we can discuss with you under malaria management, where we have seen we have started with the life cycle, we have seen different drugs which affect different stages, and we have seen the malaria policy, which we are using to manage the guidelines we are using to manage malaria. And we said in case of relapse, you treat someone after 2 weeks comes back. After 2 weeks comes back, please use Primaquine. We are using Primaquine as a radical cure for managing this malaria relapse. Or if you see other stages which are non-PF, you can either use Chloroquine or you can use Primaquine. So thank you so much for learning with us at Medical Sciences. If you have enjoyed this video, don't forget to like the video. Subscribe if you haven't. Share to many others that we may continue to grow. May God bless you. Thank you so much.